Our next speaker is Dr. Sayuj Krishnan, who has trained in Amrita Kochi and has grown ahead of his age and times in endoscopic spine surgery.
I'll be going straight in the case. This is a 34-year-old male working as a Zomato delivery boy, present with complaints of radiating pain, with radiating pain of the right side. On motor examination, he has grade 5 power node formalins, light S1 hypoesthesia with a straight leg positive on the right side. This is the MRI showing the L5 S1 disc. So this is the interlaminar approach. So we place the CM guidance interlaminar and place the incision till the fascia. And this is done under epidural. This is the dilator, initial dilator, and then this is the trocar which is going inside. Patient is completely awake, and through which we enter with the endoscope. This is the initial forceps, the muscle dissection, and this is the flavum ligament. So we start cutting the flavum from the midline and towards the lateral. So initial flavotomy. The epidural, the dura is visible, means root is visible, the inflamed root, and we go till the lateralmost part of the flavum is cut, and then we retract the root, and then this is the disc fragment, and then we slightly rotate the scope, and the disc fragment is extracted out. This was this is the only initial fragmentectomy. That was the initial fragmentectomy, but this was a further calcified disc inside. So again, today morning, Dr. Ajit sir was talking about the removal of the calcified fragment through the endoscope. So this is a knife which we can use to cut further the calcified portion with the knife, and then it was a calcified portion in the upper end plate. And that is being extracted using a forceps. Coming to second case, is a 62-year-old male with again pain radiating to right thigh and grade 5 power node limbs with THL and dorsiflexion weakness. So this is a L4-5 inferior migrated disc. For a L4-5 disc, usually there is a transforaminal approach also can be done. So this is the initial needle placement, and this is the incision. We insert a needle into the disc space, guiding into the disc space through the Cabin's triangle, and then the dilator. This is done using a rectus spinal block either or using a epidural also. And then we put the trocar again. So initially, after entering the with the trocar, we just rotate the trocar in order to see the epidural, the inferior part of the facet. Sometimes we may need to drill the inferior part of the facet, but again, initial discectomy is done. Intradiscal debulking is done, but the inferior part, after the initial intradiscal debulking, we again this is the bipolar we use to shrink the tissue, and the disc fragment is being extracted. After this, again there was an inferiorly displaced fragment. This is the posterior longitudinal ligament, which is again cut, and then sometimes the disc fragment is in the epidural space, so we may have to remove this posterior longitudinal ligament and then get into the space. So here there was a disc going into the inferior fragment, and then using this bipolar forceps as a dissector, this fragment was removed. So that was the inferiorly displaced fragment. Here you can see the above is the epidural fat. This is the upper and lower end plate, and that disc is being removed. Coming to third case, it's an IT professional with a neurogenic claudication, L4-5 disc with in axial section. You can see that there is a stenosis, L4-5 stenosis. So here is this is a stenosis scope. Which previously it was an interlaminar and transforaminal scope. We are used the root is visualized on the other side, and then the opposite. This is the opposite flavum, and then this is the opposite root, which is after the stenosis work. The bilateral both sides over the roof decompression is done. The facet, part of the facet is removed, and then the opposite root you can see the epidural fat, the dura, and then and this is ipsilateral root, and both sides is free of, no instrumentation was done in that. This is a 38 this is a 52-year-old lady with low back pain, again with the instability pain, with bilateral EHL weakness. This is L4-5 grade 2 listhesis, and this was the initial planning using navigation, and using an endoscopic trajectory, we put a cage inside, and then using this thing navigation guided, we have placed the this is a discite, is again endoscopic removal of the disc and then starting the antibiotic, and in epidurally endoscopically we were able to deliver the drug also. So that's the so that was the case. So the this is we can do this spine surgery looking up, and that is more ergonomically feasible for the surgeon also in terms of ergonomics. Thank you.
Good presentation, relevant topic 2. Any discussion from the audience?
Cases you said that the calcified fragment you cut with something. What knife you used?
There's a knife with a three-sided knife that comes with the endoscopic instruments, which that can be, there is a sharp instrument.
Okay,
but
so
on one side the root is protected on the one side, so through the tube, if we use that sharp instrument, there is no risk of dural injury.
So it cuts much sharper than the conventional number 11 blade.
It's very, very sharp.
The second thing, when you do intradiscal removal of the disc, what's your end point?
In a transforaminal approach, I do the intradiscal decompression just to access the epidural space. That is the only approach, because if the disc protrusion in the epidural space, there is not much point in the intradiscal decompression. If I can get the fragment from the epidural space, I am happy with it.
Good presentation, Dr. Sahaj, Dr. Mahesh from Kannur. The two questions. First thing is, what is the time duration that you generally take for interlaminar as well as for the transforaminal approach?
1.5 hours.
Both same around?
Around the same, yeah.
And the second question was the second case that you showed, L4-5 migrated disc.
Yeah.
Why did you opt for a transforaminal rather than a interlaminar? Because especially, with a transforaminal, there is a risk of leaving something behind there,
Yeah,
because, migrated disc.
Yeah,
So,
yeah,
was there any
because
specific reason? Because I would have opted for interlaminar rather than a transforaminal approach.
sometimes if the disc is so much lateral, then if you go interlaminar, then to get to the lateral most portion is difficult, which will be more easy if we go subarticular disc and everything will be more easily accessible to the transforaminal approach. In interlaminar approach, you will directly land into the disc, but this fragment under the facet especially, it may be difficult.
Yeah, we may have to drill some part
Yeah,
of inferior
drill the
lamina.
fat, yeah.
Lamina, I mean, it may take a little bit,
More drilling,
more time.
Drilling.
But I felt that, inferior migrated, probably it would have better.
Yeah, both are.
If there is some foraminal stenosis,
Yeah.
how will you address?
Foraminal stenosis also, I usually drill I use a drill to drill the lateral part of the facet and go into the foraminal lateral recess part, and then the drill I have not shown. There's a endoscopic as to drilling. Thank you.
Thank you, Saish, for that. There are two concepts which are highlighted, I think. The awake spine surgery and the day case spine surgery, which are coming up now. So you are able to admit and discharge the patient on the same day.
Same day, yeah.
Very good.
I request our chairpersons to please hand over a memento and certificate.